help
Hello, good morning and welcome to today's presentation on preeclampsia, where we are going to look at the management of an eclamptic seizure. Now, before we proceed, in our previous video, we talked about the antihypertensive drugs which are suitable for the management of preeclampsia. Now, I want to stress that prolonged use of beta blockers may reduce fetal growth, and also we should try to avoid the use of ACE inhibitors in the management of preeclamptic patients, since they are associated with oligohydramnios, stillbirth, and also renal failure. Now, we also have to avoid the use of SC-nifedipine because it causes rapid changes in the placenta circulation, which may also compromise fetal circulation. Now, having said that, I also want to stress that a fluid bolus of about 250 ml of normal saline or even Ringer's lactate should be considered before commencing our IV antihypertensive therapy. This is because there are evidence which suggests that this may avoid the hypotension which is observed with the initiation of these vasodilators. And so giving a fluid bolus of 250 ml before you start may obtain this effect. Now, after managing the blood pressure, the diastolic has fallen to about 90 millimeters per mercury. We've given Ringer's lactate to this patient, and it is at a rate of about 85 ml per hour. And what we are aiming for here is a urine output of more than 100 ml in 4 hours. Now, I want to stress over here also that we shouldn't over infuse this patient, since excessive fluid administration is harmful in severe preeclampsia, and so we should, as much as possible, try to restrict the fluid that we give to these patients. Now, we are observing the blood pressure. Oxygen saturation is also being monitored. The heart rate and also the respiratory rate are all being monitored over every 15 minutes. Now, whilst we are planning to deliver, this woman, she gets a grand mal fit. So, what is the most likely reason for this fit, and how do you think it should be managed? Now, the fit is most likely to be an eclamptic fit. This is what we call eclampsia. Now, when we say eclampsia, it is a life-threatening complication of preeclampsia, and eclampsia, is the convulsive phase of an established preeclampsia, often in the absence of other causes such as metabolic cause or even neurological cause. So once you are able to rule out that this fit or these convulsions has no metabolic cause or neurological cause, then we can attribute it to a complication of the severe preeclampsia. Now, it is known that eclampsia is often preceded by premonitory events such as severe headache and also hyperreflexia, and also these seeing flashes of light. However, it may also occur without these premonitory signs. And it is also interesting to note over here that eclampsia can occur before, during, or even after labor has commenced. Now, other causes of this fit in this situation may include epilepsy, and in this case, we may have a neurological cause of it. Also, intracranial event when the patient has such a high blood pressure to the extent that she may get subarachnoid hemorrhage and also may have a cerebrovascular accident. In these cases, this patient may also go into fit. Also, when we have vasovagal event, whereby we have a very rapid fall in the blood pressure due to these antihypertensive drugs or these aggressive management of hypertension. You may also have fits occurring in such patient. Hypoglycemia may also complicate this case, and may also cause fits or convulsions in such patients. And so we should be able to rule out all these other occurrences of fits in order to establish that eclampsia has occurred in this woman. So once we have seen that eclampsia has occurred in this woman, how do we go ahead to manage this woman? Now, the patient, our initial management of this patient is that the patient must be turned into the left lateral position. Our aim for turning this patient into the left lateral position is to prevent aortocaval compression, and also to help drain secretions which comes in the woman's mouth, including vomitors, so that they may drain from the side of the mouth. If the woman is left in a supine position, the tendency for this woman to aspirate when she vomits is very high, and so we encourage nursing this woman in the left lateral position. Immediately, you must call for help, because you cannot manage this woman alone. You need the supporting staff, nurses, anesthetists, and other people to come in to help with the management of this patient. And moving on, you must assess and support the airway, the breathing, as well as the circulation. So don't forget your ABC in the management of these patients. So with the airway, you must make sure it is cleared. If the woman is vomiting, make sure you suction every vomitors from the woman's mouth, and make sure you keep this woman as comfortable as possible. And make sure there are no vomitors or materials which are occluding the airway of this woman. You can also implement the technique of jaw thrust and chin lift to help this woman airway to be cleared. We also have to support the airway with bag and mask ventilation after we have suctioned everything from this woman. You cannot start bagging this woman with a mask and bag when this woman is having vomitors, in the airway, in the mouth or in the airway. You must make sure you suction everywhere. Suction through the mouth, suction through the nostrils to remove all secretions and fluid from the airway. Now, we also have to check and measure the oxygen saturation and make sure it doesn't fall below 95, some say 90 percent. Now, if the airway is if the airway is being obstructed with all these things that you are doing, the anesthetist must come in to secure the airway by intubating this patient so that further management can be continued. Now, with the breathing, with the circulation, we must obtain IV access and start with our infusions, and also give, if it is indicated that this woman is hypoglycemic, you have to start managing hypoglycemia by giving 50% of 50 mils of 50% dextrose saline to this woman. Now, we also have to treat this woman with IV magnesium sulfate. We have to treat this woman with IV magnesium sulfate, and we must monitor the ECG, the blood pressure, continuous monitoring of blood pressure, continue to observe the respiratory rate and ensure that the respiratory rate is not reducing below 12 cycles per minute, and also continue to monitor the oxygen saturation. Now, as I've said earlier, we have to check the blood glucose level, since we said hypoglycemia may also complicate these cases. Now, how do we give the magnesium sulfate to this patient? I've summarized everything over here. And the first thing that we do is we draw up 8 mils of 50% magnesium sulfate, which is 4 grams, and we dilute with 12 mils of normal saline, preferably the 0.9% strength. This will give us a volume of 20 mils. That is, you drew 8 mils and you added 12 mils of normal saline. So together you are going to get 20 mils of this drug. Now, you give all these 20 mils, that is the 4 gram, slowly over 10 to 20 minutes. Do not give it very fast, since if you give it so fast, you may have other cardiac complications associated with it. Now, you can follow this with a loading dose after you've commenced or after you've started this drug. You can continue with your maintenance infusion, and with the magnesium maintenance infusion, we give magnesium sulfate at 1 gram per hour. And over here, what you do is you take 20 mils of the 50% magnesium sulfate, which is 10 gram. Then you dilute it with 30 mils of normal saline, still with 0.9% strength, and you are going to get a total of 50 mils. Also, this is because you took 20 mils and you added 30 mils of normal saline. So you are going to get 50 mils. Now you are going to give this IV using a syringe driver or whatever at a rate of 5 mils per hour. Now, how do we manage seizure whilst the woman is on magnesium? So we can give magnesium sulfate 2 grams bolus. So over here we take 4 mils of the 50% magnesium sulfate, which will be 2 grams, and dilute with 6 mils to get 10 mils. Then we give this over 5 minutes. Now, it is important for me to indicate over here that whilst we are giving this magnesium sulfate, we must try to stay within the therapeutic level. And the therapeutic level will be 2 to 4 millimole per liter. Now we can continue to monitor the the levels of magnesium clinically. For example, if there are loss of reflexes, it may indicate that this woman has received more than 5 millimole per liter of magnesium sulfate. If this woman also exhibits signs of respiratory distress or reduced respiratory rate, then it may mean we've given about 6 to 7 millimole per liter. And so we must observe the woman whilst we are giving these magnesium sulfate to her, in order to counteract any side effect of the drug, and also in order to avoid the overdosage of the drug. Now, we need to reduce the infusion rate when there is oliguria, because this may lead to cardiac arrest when you give more than 12 millimole per liter of magnesium sulfate to this women. Having said that, we realize that a bolus of magnesium is administered, and she is commenced on an infusion of magnesium at a rate of 1 gram per hour. Now, her respiratory rate and reflexes are checked regularly, and she is being nursed in the left lateral position. Now, the cardiac tachography is demonstrating repetitive and severe fetal heart rate accelerations, and a decision has now been made for an emergency delivery by cesarean section. The anesthetist attempts to make a plan for anesthesia. So over here, what do you think should be the most appropriate anesthetic technique? Should it be a general anesthesia or a regional anesthesia? And should women with severe preeclampsia be encouraged to have regional anesthesia for cesarean section? Join me in the subsequent video as we look at how to give anesthesia to this woman. Thank you very much for your time. Bye-bye.